Hello, my name is Dr. Tharani Theivakumar, and our project is on CBCT significance for orthodontic treatment planning. I am also working on this project with another R1 orthodontic resident, Dr. Christina Casilia, and our PI for this project is Dr. Kimberly Jones-Rudolph. So just some background or overview about the significance of our project. So currently there is a lack of consensus among the orthodontic community regarding the use of CBCTs as a standard of care. Currently, the AAO recommends that CBCTs only be used in specific cases, and the literature on the indications and applications of CBCT findings on orthodontic patients' diagnosis and treatment planning is pretty conflicting. Historically, orthodontists have always been reluctant to embrace change. For example, when cephalograms were first introduced into orthodontics, there was a resistance and a lack of consensus for routinely implementing them. However, now ironically, they're used as a standard of care. So this historical analogy can kind of be similar to the resistance of using CBCTs as a standard of care. So the objective of our study is to help illuminate the utility of CBCTs in orthodontic practice. So I'm going to go over some literature background, but I just wanted to add a tidbit about the grant proposal writing process. So for me, for the grant proposal, I would say the most difficult part was that literature review. We had to do an extensive literature review and read a bunch of articles, trying to find support to help us say why our study is so significant or why there's so much conflicting evidence on the use of CBCTs. And I would say the other most difficult part was coming up with the methodology for the product, like the study design, and like figuring out the statistically significant number of patients to use. And I guess last, just in general, the grant proposal writing process, there's lots of different criteria or sections in the grant, and you basically have to follow all the directions to the T. So it's pretty detail oriented and nitty gritty. So that was my tidbit on grant proposal writing, but we'll forget about that and get back to the background significance. So these were kind of a summary of the findings that we found on why CBCTs are beneficial and compared to panoramic radiographs. So the first reason they're more beneficial is one is that CBCTs provide greater resolution and reduced distortion and allow for 3D perspective of the hard tissues of the head. Two is that CBCTs more accurately evaluate patients' asymmetries and more readily determine if there's a true unilateral crossbite of the patient. Three is that CBCTs can be used for the pre-surgical assessment of cleft lip and palate, and they also help to improve the accuracy and success of placement of TADs. Four is that they are a reliable tool for assessment and management of impacted canines and help detect if there's external root resorption and root fractures. And the next is that CBCTs aid in evaluation of normal and pathological condylar shape or cortication. And finally, CBCTs help to identify and evaluate pathologies of the maxilla and mandible that may be preventing tooth movement. So this is kind of our methods or study design. So we've decided to do 62 patients because that's what we found would be statistically significant. And basically our study is going to comparatively analyze treatment plans made using just traditional methods and then treatment plans made using CBCTs. So for the traditional methods, they will use panoramics, lateral cephs, model cast, iTero scans, and both intraoral and extraoral photos. So they'll use that to first make treatment plans, and then afterwards, they'll do the cuts and evaluate the CBCT and make a separate treatment plan. And we'll comparatively analyze if the treatment plans have changed with or without the CBCT. So our study will examine 23 different variables. So I guess there's three major categories that we're looking at. One is the patient characteristics, two is the respiratory mode variables, and three is the condylar analysis variables. So for the patient characteristics, we're going to be looking at whether there's an unerupted tooth, if there's root resorption on one tooth or multiple teeth, if the patient has a severe skeletal discrepancy, if the patient has a maxillary canine that's impacted, if the patient has TMJ problems or airway problems, if there's crowding, if there's bone loss, if there's cleft lip and or palate, if there's asymmetric growth of the mandible, if there's maxillary occlusal cant, if TADs are required or requested for treatment, and if there's variable length of the mandibular rami. For the second category of respiratory mode variables, we'll be looking at the patient's total airway volume and if the minimal cross-sectional area indicates that the patient is at risk for sleep apnea. We'll also be looking at whether there's enlarged tonsils, enlarged adenoids, or enlarged turbinates, and whether or not the patient has a deviated septum. And finally, for condylar analysis variables, we'll be looking at whether or not there's atypical morphology, if there's atypical condylar position, if the eminence or the cortication indicate pathology. So our hypothesis is that only 20% of the orthodontic diagnoses and treatment plans will change after consideration of the findings from the CBCTs. And now I'll let Christina take over.
Okay, so I will go ahead and talk about our objectives in this study. So the first long-term objective of this study is to determine if diagnosis and treatment plan of orthodontic patients will change after the consideration of CBCTs. And if our hypothesis is correct, does that determine that we have to request CBCT for each patient? So when we did our literature review, basically we saw that in a lot of articles and a lot of studies, CBCT has made a difference in the treatment planning for certain cases in patients. And we are aiming in this study to see if we have to order CBCT more often for more cases and more patients, and if it needs to be included in cases more than what the AAO recommends. The second objective is we need to see if CBCTs will lead to elimination of certain treatment plans in certain cases, or adding of new treatment planning in our patients. And this way we will make sure that we recommend it to all the patients that will need it, basically. The second, we will talk about our results. So since we don't, this research is still in process, we don't have any results yet. We are waiting on the decision for the funding from the AAO grant. Basically, we will need the money for the beam readers report, and each beam readers report will cost around $100, and so in total we need around 6,200. Now, in case we don't get the grant from the AAOF, we have to look for another funding for another organization to fund it, or for another institutions. This is one of the difficulties that we have in our research, basically. And the other difficulty is that we will do our research on a completely new patients in the clinic, so that we don't have any bias in treatment planning. And that means that we have to wait until we have a collectively 62 patients. And that will depend on the flow of the patients in the clinic, and may make the research takes longer than it's anticipated. The third thing is we have to treatment plan before without the CBCT, and then we have to do a treatment plan with the CBCT, and then we will present the treatment plan to the patients, which might complicate the waiting time for the patient a little bit and makes it longer. Next.
Yep. Can you see the next slide?
Yeah. So since our study is still in process, we don't have complete conclusions yet, but our conclusion will determine whether we should make CBCT the standard of care or not. And it will also assess whether CBCT will change the diagnosis and treatment planning of our cases. Acknowledgement, we would like to acknowledge Roseman University, our school, for their support and for this opportunity that they let us do this study. We would also like to thank our mentor,